Okay, welcome. Let's talk about the new episode. Let's start with calcium. Hypercalcemia, classically gives you stones, bones, and psychiatric overtones. But in real questions, it often looks very non-specific. Patient might come in with constipation, abdominal discomfort, mild muscle weakness, anxiety, or depression. There may be no dramatic physical exam finding at all. What you're supposed to do is you notice the subtle chronic picture and think, check the calcium. And when you see a high calcium, the first step is to interpret it properly. Know that total serum calcium is affected by albumin. So if your albumin is low, your measured calcium will look falsely low. So the corrected calcium formula should be it measured calcium plus zero point 0.8 times the difference between 4 and albumin. So if albumin is 2, you add almost 1.6 to the measured value. That will tell you that there is a true hypercalcemia or not. So once you confirm that the patient has a real hypercalcemia, the next question is what's the cause? If both calcium and PTH are high, think about primary hyperparathyroidism versus familial hypocalciuric hypercalcemia. NBME loves that distinction. In primary hyperparathyroidism, the kidney is being hammered by high calcium, so urinary calcium should be high. In familial hypocalciuric hypercalcemia, the calcium sensing receptors is faulty, so the body thinks calcium is low and holds onto it. These patients have high serum calcium, high PTH, but low urinary calcium, and they usually don't need surgery. So if the calcium is high and the PTH is low, that think malignancy because one of the cancer, squamous cell carcinoma of the lung and the head and neck produce PTH related peptide and drive the calcium up. Multiple myeloma, metastatic breast cancer can cause local bone destruction and release calcium as well. We have some conditions like sarcoidosis. This is granulomatous disease. It activates your vitamin D and increase your reabsorption. And the last point is important because there you can give steroids. Steroids can be therapeutic here. For in acute significant hypercalcemia, the treatment always starts the same. Aggressive IV normal saline. These patients are volume depleted from calcium induced nephrogenic diabetes insipidus. So you rehydrate first. Then you can add calcitonin for a quick but short-lived drop and bisphosphonates for a slower long-term effect. If hypercalcemia is driven by granulomatous vitamin D activation, steroids help by lowering the vitamin D activation and calcium absorption. Now, flip to hypocalcemia. On exams, you see it in three main contexts. After neck surgery, massive transfusions, or in genetic resistant states. So, after thyroid or parathyroid surgery, if the parathyroid tissue is removed, or devascularized. PTH falls, calcium falls, and the patient can present with perioral tingling, muscle cramps, tetany, and seizures. On exam, you see hyperreflexia, a positive chopstick when you tap the facial, when the facial twitches, and the positive trousseau when you inflate a blood pressure. Cough, it triggers the carpal spasm. In massive transfusion, all that stored blood, it contains citrate, which gelates ionized calcium. Total calcium may look okay, but the ionized, which is a physiological active fraction, it drops and gives the same neuromuscular irritability picture. There's also pseudo hypoparathyroidism, where PTH is high, but the kidney is resistant to it because of a GS protein defect. So levels show low calcium, high phosphate, and high PTH. The classic phenotype here is they have a short stature, round face, and shortening of fourth and fifth metacarpals. So you see dimples where the knuckles should be. And for symptomatic hypocalcemia, you give IV calcium gluconate. For milder and chronic hypocalcemia, you can give oral calcium and vitamin D. Um, Now let's talk about sodium and osmolality and the link that too with the small cell lung cancer and paraneoplastic syndromes. Serum osmolality is estimated. We have the formula: 2 times sodium plus glucose divided by 18 plus 1 divided by 2.8, and the normal is around 280 to 9 to 290. If a patient has low sodium but normal osmolality, you have to think pseudo hyponatremia from hyperlipidemia or very high protein like multiple myeloma. If the osmolality is high, look at the glucose. Severe hyperglycemia pulls water out of the cells and dilutes sodium. So if for every, for every 100 mg per dl rise in glucose above normal, you add about 1.6 to the sodium to correct it. What's the classic for SIADH? We call it euvolemic hypoosmolar hyponatremia. These patients have low sodium and low serum osmolality, but inappropriately concentrated urine. They have the high urine osmolality, high urine sodium. We have some causes of SIADH, including hypothyroidism, adrenal insufficiency, SSRIs like carbamazepine, cyclophosphamide, and yes, small cell lung cancer produces ectopic ADH uh, that can lead to this as well. Postoperative hyponatremia from pain can happen too. It behaves similarly. And the first line management in this case is fluid restriction. And if very severe or refractory, you can always add salt tablets or ADH antagonists like Veptans. Since we mentioned small cell lung cancer, NBME loves to ask its paraneoplastic syndromes. So it's a neuroendocrine and acts like an endocrine tumor. It can secrete your ADH, causing SIADH and hyponatremia. It can secrete ECTH, leading to paraneoplastic Cushing syndrome with hyperglycemia, hypertension, hypokalemic metabolic alkalosis, and often hyperpigmentation from excess ACTH derived melanocyte stimulating hormone. Also, it is associated with Lambert-Eaton myasthenic syndrome, where autoantibodies attack your presynaptic voltage-gated calcium channels at the neuromuscular junction. So it will produce the proximal muscle weakness that actually improves with use. Also, you have autonomic symptoms like dry mouth and impotence too. It also causes paraneoplastic cerebellar degeneration with ataxia from antineuronal antibodies. Um, Squamous cell carcinoma, we talked about it. It's one classically producing PTH-RP causes hypercalcemia. The last thing I want to talk here is the most dangerous part of the sodium management, how fast you correct it. So in severe symptomatic hyponatremia, such as sodium around 110 with seizures or coma, you must use hypertonic 3% saline to raise sodium quickly enough to stop brain swelling, but not so fast that you destroy the myelin in the bones. Roughly, you aim to raise the sodium by about 4 to 6 milliequivalent in the first few hours to control the symptoms, but total increase should not exceed about 8 to 10, and at most 12 in the first 24 hours. So if you correct chronic hyponatremia too rapidly, water leaves brain cells, they shrink, and you can cause osmotic demyelination syndrome. Classically, we call it central pontine myelinolysis, when the patient ends up locked in, quadriplegic, unable to speak, but awake and able to move the eyes vertically. For hypernatremia, the danger is the opposite. Dropping sodium too fast leads to cerebral edema and herniation. We have diabetes and hyperosmolar states. Let's say we have a patient with HHS. HHS is the complication of poorly controlled type 2 diabetes, right? These patients forget insulin or are stressed or infected. Their glucose goes extremely high, often above 600 or even 800 to 1000, and their serum osmolality exceeds 320 because they still have some endogenous insulin. Lipolysis and ketogenesis are suppressed, so there is little or no ketoacidosis. pH is usually above 7.3 and bicarb is above 15. They present with profound dehydration and altered mental status due to hyperosmolality. In contrast, DKA is more common in type 1 with moderate hyperglycemia hypocalcemia, we will see significant ketones and an anion gap metabolic acidosis. For both of these cases, treatment is built on fluids first, then insulin with careful attention to potassium. Insulin drives the potassium into the cells. So many of these patients are total body potassium depleted. Even if the serum potassium looks normal or high at the presentation, if you start the insulin when serum potassium is already low, below about like 3.3, you can precipitate life-threatening arrhythmias. So the rule is severe hypocalcemia, you have to deplete the potassium before or along with insulin in normal or mildly high potassium. So we start the insulin but monitor and replace as potassium falls. In frankly, high potassium with ECG changes, you stabilize the heart first, but still recognize there is a total body deficit as diuresis continues. Um, we have crisis to baseline diabetes medications, and they're classic relevant. You have the metformin. It's the first line for type 2 diabetes. It decreases your hepatic gluconeogenesis and improves your insulin sensitivity. It's a big risk factor for lactic acidosis, particularly in patients with significant renal impairment or conditions that reduces the perfusion. And so that's why you stop metformin before iodinated contrast procedures or if the patients develop acute kidney injury. Sulfonylureas, such as glipizide, it stimulates the insulin release by closing the ATP-sensitive potassium channels in the beta cells. They are excellent at lowering glucose but can cause dangerous hypoglycemia, especially in elderly patients or those with irregular meals, and they can cause weight gain as well. We have pioglitazone, which activates your PPAR gamma and improves the insulin sensitivity, but it also causes fluid retention and can participate or worsen heart failure. So they are contraindicated in patients with moderate to severe heart failure. SGLT2 inhibitors, the frozen drugs, they work in the proximal tubule to block the glucose reabsorption and increases the urinary glucose excretion. It is very helpful for weight, cardiovascular, and renal outcomes, but they increase the risk of genital mycotic infections and the UTIs, and sometimes it can precipitate euglycemic TKA, where the patient has an anion gap acidosis with ketones, but only mildly elevated glucose. GLP-1 agonist like semaglutide enhances the glucose-dependent insulin secretion. It also slows your gastric emptying and promote the weight loss. So it can cause nausea, vomiting, and have been associated with acute pancreatitis as well. They're avoided in patients with MEN2 or medullary thyroid carcinoma family history actually. So to pull this all together, you when you see all these symptoms, it's neuropsychiatric symptoms and constipation, you have to think about checking calcium, corrected for albumin and separate primary hyperparathyroidism from familial hypocalciuric hypercalcemia by urine calcium. When you see tetany after surgery or massive transfusion, you think hypocalcemia. When you see low sodium with normal or high urine osmolality, think SIADH. SIADH with small cell lung cancer, we have SIADH, we have ACTH, we have Lambert Eaton. So respect the speed limits when correcting the chronic sodium abnormality it is to avoid the osmotic demyelination or cerebral edema. That's it for today. I hope you guys like this.